Good afternoon, ladies and gentlemen, and thank you for having me tonight. Last year, I undertook an epidemiological research investigation investigating the association between health literacy and obstructive sleep apnea. And through that, I learnt a lot about public health and epidemiology in general. And tonight, I'll describe to you what I learnt through that experience. But firstly, I'll describe the research problem that I investigated. Obstructive sleep apnea, or OSA, is a recurrent upper airway obstruction that results during sleep and is associated with increased risk of cardiovascular disease, diabetes, and all-cause mortality. Over the past 20 years, the prevalence of OSA has risen in line with rising obesity and is now a considerable public health burden. Fortunately, the key challenge in meeting this public health burden is not management, because generally speaking, CPAP is quite effective. Unfortunately, the key challenge in management is diagnosis, because about 3/4 of cases of OSA remain undiagnosed. In light of this, there's a recently developed concept of health literacy, which, to oversimplify, is the ability of an individual to understand healthcare-related information. Limited health literacy is highly prevalent, even in very well-educated countries such as Australia, and it's associated with worse disease knowledge as well as adverse health outcomes. And most notably, this is the case in diabetes and asthma and other chronic diseases. So, for example, if you don't know how to use your puffer, you're not going to be able to manage your asthma very well. In theory, if somebody has poor health literacy, then they won't understand that snoring and daytime sleepiness and other pathological symptoms are worth presenting to the GP to have assessed, and so as a result, it in theory would be more likely to have an undiagnosed OSA. And so as a result, we investigated this association due to the paucity of previous data in the males cohort study, which is a community dwelling cohort of about 1,600 middle-aged men. And specifically, we investigated the association between health literacy and the diagnosis of OSA, health literacy and the presence of OSA itself, as well as health literacy and the presence of OSA-related risk factors such as smoking, alcohol, and sedentary lifestyle, as well as related comorbidities, for example, cardiovascular disease. Our measure of health literacy was the newest vital sign, or MVS, one of many validated health literacy tools. And this health literacy tool is based on the participant interpreting this ice cream tub nutrition label and asks 6 questions. The number of correct answers that they give provide the participant to be classified in either the inadequate, at-risk, or adequate health literacy categories. To determine OSA, we did it in 2 stages. Firstly, we asked the 1,600 participants via computer-assisted telephone interview, do you have a previous diagnosis of OSA via a sleep study, of which amongst those with complete data, 162 men answered yes, we've got OSA. Of those that said no, we don't have OSA, a random sample of those were given polysomnographies or sleep studies, and of those with complete data, about 382 were determined to have previously undiagnosed obstructive sleep apnea. Now, comparing these 2 groups, the undiagnosed and previously diagnosed men were of similar status in terms of financial stress and education level, but those with undiagnosed disease had slightly higher annual household income and were slightly younger than those with an established diagnosis. And indeed, putting these groups in an adjusted logistic regression model that's adjusted for all the confounders listed at the bottom of that slide, we found that inadequate health literacy was associated with a 2.8 times as likely odds of having undiagnosed disease. And this evidence suggests that inadequate health literacy may be a barrier to diagnosis of OSA. Inadequate health literacy amongst the polysomnography cohort was also associated with increased prevalence of OSA, and this may be partially perhaps mediated by the increased risk of sedentary lifestyle among these men with a previously undiagnosed OSA. amongst the men with an established diagnosis of OSA and therefore presumably treated OSA, inadequate health literacy was associated with increased risk of cardiovascular comorbidity. And so from this research, there are two main findings of public health importance. Firstly, that inadequate health literacy is associated with a lack of OSA diagnosis. And so as a result, future studies should investigate whether public education campaigns such as TV ads about the importance of snoring might be helpful in increasing the rates of OSA diagnosis. The second major finding was that inadequate health literacy was associated with cardiovascular comorbidity in the men with an already established diagnosis of OSA. And so patient education at the point of diagnosis may help improve cardiovascular comorbidity in the long term, in a similar way, I imagine, as how diabetes nurse educators currently educate newly diagnosed diabetics and thereby help improve their glycemic control. And so reflecting upon this research, this 6-week research elective that I undertook, I learned a lot about public health and epidemiology, but in particular in relation to competency element 3.2.4. When this research was first conceived, I had to write a research proposal in order to gain access to the cohort study data. And the process of defining the objectives of the research, and in particular specifying the specific hypotheses, allowed me to learn that A, the specific hypotheses have to be relevant and important to public health, and B, they also need to address the gaps in the existing literature. Then using SPSS, which is one of the many statistical software programs, using the crosstabs function to undertake the descriptive chi-square analyses and the logistic regression function to undertake the multivariate analyses allowed me to gain experience in those epidemiological analyses. And one of the most important things that I did was to record a research diary of all the syntax that I used. And so after I almost completed my research rotation, I looked back on the syntax that I did on the first day, and I realized it was just rubbish. And so going back over that syntax and correcting all my mistakes was very valuable in getting a bit of the experience in the practicalities of epidemiological research. Of course, in terms of epidemiological research in general, I learned a lot about bias. The males cohort study is a random community sample, and so that minimizes selection bias at baseline and increases the representativeness of the cohort compared to the population of South Australia. Unfortunately, we don't have a weighting variable, and so at follow-up, we were, the current health literacy project uses stage 3 cross-sectional data, so at that follow-up, because of the non-random attrition in the first 2 waves, the participants reported slightly better education level compared to the population of Australia, and without the weighting variable, we weren't able to account for that, unfortunately. Also, there are a number of analyses that we undertook, and so some of the positive associations may be type 1 errors rather than true associations. And due to the small sample size, you note in particular the subsample of previously diagnosed men only had a sample size of 162. And so some of the elevated but non-significant odds ratios that I didn't show here but are in the published paper may represent type 2 errors rather than true lacks of association. And as with all observational research, there is confounding as well. In terms of public health in general, I've learnt that we need to look at the big picture. For example, as an individual clinician, if our patient doesn't have adequate health literacy and as a result doesn't successfully engage with the healthcare system, then we won't see them in the first place, and so we won't be able to help them. We also can't combat high prevalence disease by ourselves. Doesn't matter how many patients we see in the outpatient clinic, for example, for obesity. You know, it's only a drop in the bucket compared to the millions of Australians that have obesity around the country. And so to combat this, we need public policy. We need education, for example, about snoring. We need health system reform. We don't have a very large cohort of sleep specialists, and so we need new models of care to shift that away from the sleep physicians and more towards upskilled GPs. And we need preventative medicine to prevent the rising tide of obesity and related diseases. And so to summarize, I undertook an epidemiological investigation of health literacy and sleep apnea. And along the way, I learnt a number of things about public health, in particular, performing suitable epidemiological analyses. And I'd finally like to thank everybody that's made this John Snow Scholarship Journey possible. Firstly, the first 3 dot points, my research supervisors and research collaborators, as well as a special thanks to Dr. Louise Flood, Dr. Doug Shaw, Dr. Marianne Gillam, and Professor Peter Clifton, who gave me very valuable feedback on this presentation. Thank you.
Thank you very much, Joule. Do we have any questions for Joule? Yes, Charles.
That was great. Thank you very much. I wonder if you'd like to reflect on the definitions of health literacy in the light of your study, and also on the utility of current diagnostic methods for OSA given the size of the problem.
Sure. So that's a really good question, and there are a number of layers to that question. I'll address them in turn. Firstly, in terms of health literacy, health literacy is a very broad concept with multiple domains, and there's sort of a spectrum of tools that have been developed to assess health literacy. On the one end, we have the newest vital sign, which is what was used in this study, and that's a short 3-minute, 6-question tool that obviously isn't very thorough, but is very quick in terms of the clinical context and was actually developed for use in general practice. On the other end of the spectrum, we have the tools that are used, for example, by the Australian Bureau of Statistics in the Adult Life Skills Survey, which take hours for each participant to complete, but cover virtually every aspect of health literacy. And then we've got all the ones in between. So we have the TOEFL, which is a test of functional health literacy in adults, and we have newly developed in the eastern states by Professor Osborne and colleagues, we have the Health Literacy Questionnaire, or HLQ. And so there's no one health literacy measure that's perfect, but in terms of the newest vital sign, which was used for this study, the prevalence rates that on a population level that identifies as having less than adequate health literacy is similar to that of the prevalence rates found by those very thorough ABS measurement tools. And so I think for our purposes, it is relatively sufficient within the limitations of the cohort and within the limitations of funding the cohort study. In terms of your second question, which was in relation to diagnosis of OSA and management of it, it's sort of there's a pipeline of the patient journey, and health literacy really addresses that first step in the pipeline, which is presentation to the GP. There are other steps along that pipeline, which is the GP assessment of OSA, which is in the main, in terms of that aspect, are the screening questionnaires. So we have the Berlin questionnaire, we have a newly developed OSA 50, for example, we have the Stop-Bang questionnaire. Unfortunately, all of those questionnaires, they have relatively high sensitivity, but very low specificity. It's only about 60-70% specificity. And so the GP is going to be sending a lot of people that don't have OSA for specialist referral because we don't have very good screening of OSA in the first place. And so in terms of, I guess, improving the OSA diagnosis pipeline, so to speak, we need to improve the questionnaires and the screening at that level as well, not just patient health literacy. And then on the third step of that pipeline is the specialist capacity. And so, if you look at the original prevalence numbers, about 10 to 15% of the general population have undiagnosed obstructive sleep apnea in the current obese climate. And so that, if you take that into the Australian population numbers, that's upwards of maybe 1.5, 2 million Australians that have OSA. We only have maybe 500,000 sleep physicians. So without a new model of care where there's a shared burden between GPs who are able to assess and diagnose and treat high probability simple cases of OSA, we won't be able to manage the sheer number of OSA patients that are coming through. And so there are those three aspects of the pipeline.
Thanks for that very comprehensive answer.
Thank you. A very good presentation. Did you find any influence, the effect of Dr. Google on health literacy?
Unfortunately, we don't have any data on that. I think it's I think in the general population, snoring is considered to be something that's relatively benign, because we used cross-sectional data from the third wave of the cohort. But I actually looked back on for the first wave of the cohort to see if they reported snoring and observed apnea symptoms back then, and actually about 30% of that stage 1 cohort had those OSA symptoms. So 30% of the men that now have undiagnosed OSA had those symptoms back 10 years ago in the first wave of the cohort. So they've been snoring for 10 years and they still don't have undiagnosed OSA. And so I think to answer your question so specifically, if they have been Googling stuff, they certainly haven't been seeing the GP to have it assessed if they've had snoring for 10 years and
So
still not have it diagnosed.
Had minimal effect, really.
Yeah.
Any other questions? I actually wanted to ask you, you've talked about educating people about snoring, but if the basic problem is people's poor health literacy and a wide range of things, how do you think we might be addressing that as a health system?
I'm sorry, I was just wondering if you could clarify that.
Well, you've talked about health literacy as a concept, and I think the questions that you asked did not really relate directly to OSA. They were about other aspects of health literacy. So if we want to increase health literacy of the population, have you got some ideas from your research about how we might do that so that people can be more literate about a range of things, not just OSA or nutrition on ice cream labels?
Yeah. I think it's a really big challenge because like once people finish school, it's very difficult to engage them in community education programs. Like our research group, for example, does have a regular sort of monthly public, like general public information session, and the attendance to that's maybe 30 or 40 men, which is all right, but it's not nearly enough. And so in terms of that, it's quite difficult to engage, and I don't have any silver bullets or magical ideas, unfortunately, on how to do that. But I think like about 10% of the population, when you answer the newest vital sign, they can only answer either 0 or 1 question out of 6. And so if I didn't actually have the time to go through what those questions were, but just to give you an example of these questions are what we as educated healthcare clinicians would consider very easy. And so one question that is asked is, if you have a peanut allergy, would you be able to eat this ice cream? And the answer is no. And then the follow-up question is, why? And the answer is because the ingredients contain peanut oil. And so if you answer those 2 questions correctly, then that's already 2 marks out of 6. And so you're already above the inadequate health literacy threshold. So it's very surprising and very challenging that about 10 to 20% of the population aren't even able to answer those 2 questions correctly. And if you add in the at-risk individuals, which are those that still aren't getting more than half of the questions correct, that the prevalence of inadequate or at-risk health literacy is about 40 to 50% in the Australian population. So that's a big challenge in terms of trying to bump that up to an adequate level.
that very nice presentation. It seems to me that the populations of both Australia and New Zealand are heavily burdened with obesity and awash with chlamydia as well. So I just listened before tea to a presentation in the general medical stream on sleep apnea, and the consultant, of course, I mean, the diagnosis has always, or for a long time, been linked to hospitals and the various techniques used. But he was concerned about the numbers that might be detected. What do you think could be done if they start by screening the obese people for sleep apnea, which he seemed to recommend, and what should be the sort of way of going about medical care?
Yeah.
Probably.
So I guess I'll answer two aspects of that question. Firstly, the identification of individuals to screen. And I think classically, according to the textbooks, OSA is described as a male, an obese male, middle-aged disease. But actually, the prevalence of OSA in women is actually very high. And the two most common clinical phenotypes of OSA in women are asymptomatic resistant hypertension and asymptomatic morbid obesity. And that those two phenotypes alone account for 80% of female OSA. And so, firstly, before we talk about population screening, I think we need to have more research on exactly what clinical signs and symptoms females with OSA have. Because, when you have 80% of women with OSA that don't snore and don't have daytime sleepiness above that what they consider normal, the classical textbook presentation that we've learnt as clinicians is not valid in that cohort. The second part of your question is in relation to how do we manage this this increased number, and I think traditionally we've had OSA diagnosed in the in-laboratory overnight full PSG sleep study, and recently there are new technologies for this. So on a various spectrum from the full laboratory to, on the other end, there are wrist actigraphy measurements where people can take home a wrist actigraph and go home, sleep, and then they get a oximetry measure that they take to their GP, and they can determine with decent sensitivity and specificity and area under the curve whether or not they have OSA from that. And then there's also everything in between. So there's home PSGs now, for example, that are accessible. And so I think to get to the large number of potential OSA patients that Australia and New Zealand are going to face, we need to move away from this gold standard in-laboratory PSG to some of these newer methods such as wrist actigraphy and home-based PSG. So a wrist actigraph it only costs about $20 to $40, which is much better than. So CPAP, yep. So CPAP is relatively expensive actually. It costs a few $1,000s, and so I think that is a barrier to treatment. And unfortunately I'm not aware of any sort of new technology that is cheaper than that. I did notice that there's a poster outside for cheap CPAP in the developing world, using recycled materials that will cost about $20 or $30. But I'm not sure whether that seems like a fantastic idea, but I'm not sure whether it will take on here in Australia and New Zealand.
Thank you very much, Joule.
Thank you.